Dear viewers, welcome you all to our show Orthopedic Solution Academy. Hope you all are well with your friends, family, and definitely with your patients. Dear viewers, today we will discuss about a topic that is slap repair. We discuss about many shoulder topics in our program, in our shoulder clinic program. And the speaker is the one and only Professor G.M. Jahangir sir, the pioneer shoulder surgeon of Bangladesh. I'd like to request Dr. G.M. Jahangir sir to join with us.
Thank you, Dr. Tanvir Ashraf, for inviting me in this academic session of shoulder clinic of orthopedic solution.
Thank you very much, sir, for joining with us. Dear viewers, we have learned academic expert with us, that is Dr. Rajeev Raman, sir. Hope he will connect with us in the coming part of our program. Dear viewers, we all know that many patients are suffering with different types of shoulder problems. We discuss about a topic regarding the shoulder problem in this shoulder clinic. And today, the topic is the slap repair. Now, I would like to request our honorable speaker to share his screen and start his magnificent presentation. Sir, would you please share your screen and start your presentation, sir?
Thank you. My slide is visible
Yes, sir. It is,
and
it is,
am I audible?
yes, sir. You are perfectly audible and slides are completely visible, sir.
Okay. Dear viewers, Assalamu alaikum. I am Dr. G.M. Jahangir presenting to you a common problem of the shoulder. There are many problems, among them slab tear is important one of them, and it is mostly seen in especially sporting person like overhead activities and contact sports, and as well as wrestler who lift weight to overhead. So I am going to present my next slide. That is, a slab lesion is an injury to the superior labrum near the attachment of the long head of the biceps brachii anchor. Deep and posterior shoulder pain, catching or sorry, locking uh, of the shoulder during overhead sports or activities of daily living. The clinical findings of the slab tear are non-specific and radiographic diagnosis is imprecise. So it is a miracle when we diagnose a slab tear clinically as well as radiologically. So we be careful about the diagnosis of about the slab tear. There are many mechanisms of slab injury. Among them, traction or twisting injury from the biceps tendon during the late cooking phase of throwing, mostly in abduction and external rotation. This type of injury mostly we can see among the cricket like fast ball player and the long tennis uh, player, and also the badminton player. And again, there is also slab tear by traction injury from the biceps during the deceleration phase of throwing. Usually, a throwing has uh, early cooking phase, late cooking phase, and accelerating phase and deceleration phase. These all phase are important, but among the deceleration phase, there is also biceps uh, uh, tendon as well as slab tear can happen. And other mechanism of slab tear, when a player or when any person fell on the outstretched arm or hand, you can see the figure right above. So we can fell on the hand, and another figure shows that the player fall on his shoulder directly. All this causes the slab tear. There are several types of slab tear, which are more diagnosed mostly by uh, uh, arthroscopically as well as imaging like MRI. Type 1, when there is, you can see here, there is a, in diaphragmatic fever, there is superior labral is spraying here, biceps and anchor is intact. And there is also arthroscopic view, we can see that is fraying of the superior labrum. You can see there is fraying of the superior labrum, which is called type 1 slab tear. In this situation, mostly bicep anchor is intact. And type 2, there is a superior labrum is detached from the glenoid and bicep anchor distorted, most common. This type of slab tear is important for us, for both patient and the clinician, especially shoulder arthroscopic surgeon, because these patient impair the uh, daily activities or regular sporting activities of the patient, and which causes weakness of the limb and unable to throwing or lifting or pushing and pulling effect of the arm. And this is commonly, you can see that is the arthroscopy figure. There is a whole superior laterally detached with the biceps anchor. Here is biceps is mobile here. And type 3, a bucket handle tear of the labrum that may displace into joint, labral bicep attachment intact. You can see just like bucket handle tear of meniscus. This portion of superior labrum is detached and protrude into the joint. And but here is bicep anchor is intact. That means bicep tendon is stable. So treatment may be only just hand. It causes locking, catching, or blocking the shoulder, especially during the upper head over the shoulder activities. In this situation, we only debride the uh, handle where portion of the labrum, and patient relieve all type of symptom. And type 4, bucket handle tear of the labrum that extend into the bicep tendon, allowing the tendon to subluxe into the joint. You can see bucket handle tear also, the tendon extends into biceps tendon. You can see diagrammatic figure where the torn extend the biceps tendon. In this it is, but in this situation, the maybe bicep anchor is partially maybe torn or intact. And type 4 slab 2. That means here is a bicep anchor is distorted with anterior bankard extension. You can see the figure right above. That is complete tear of superior labrum with associated bankard lesion. That is type 5. And type 6 varieties here, a free flap of superior labrum with type 2 injury. This is free flap and type 2 injury. There is type 6 and type 7 slab 2 with capsule MGHL extension. This is superior labral detachment and that may extend into the uh, middle glenohumeral ligament. All this leads to uh, uh, unstable superior labrum. That is type 2, type 5, 6, and 7. All are in this situation are bicep tendon are unstable, and this type of slab tear needs intervention, especially arthroscopic repair. By some, there are clinical tests by which can assume there is uh, slab tear, but also this is the test of impeachment, maybe sometimes impeachment condition, this test may be positive, but O'Brien active compression test more positive in case of slab tear. And slab tear when there is a pain deep in the glenohumeral joint while the forearm is pronated, but not pain when forearm is supinated. That means when thumb directed downwards and physician arm is 90-degree abduction and 15 to 20-degree adduction, then clinician or physician downward pressure above the wrist, but patient resists. In this situation, if there is deep pain within the shoulder, it indicates there is a torn of slap tear. But when there is relief of pain, or when there is arm is supinated, that means thumb is directed upward, the pain relief. Again, it indicates the slap tear which causes pain, and it released by during supination condition. It is a active compression test by O'Brien test. And other crank test, in this position, patient there is a clicking or pain in the glomerular joint, that is called crank. That is, hold the patient arm in abducted position and apply axial load and passive rotation, that means external rotation and internal rotation with axial loading causes pain. That is, there is a positive, there is when there is a lateral tear. And also bicipital group tenderness, it indicates when there is a superior labral injury associated with biceps tendinitis, or bicep tendon is unstable, either subluxated or dislocated. It also one of the indicator of slap tear. And another speed test, in this situation, supinated arm is elevated against the resistance of the physician or clinician. In this situation, hand is supinated and elbow is extended. If there is slap tear associated with biceps in anchor involvement, causes pain. This is also a speed test for another test for diagnosis of slap tear. And irrigation sign. In this situation, elbow is placed and patient is try to supinate his forearm against resisted, and if there is injury slap associated with bicep tendon involvement, this causes pain. This is also one of the tests for indicate that is biceps lesion uh, occurring in the shoulder joint. So next we come to the investigation, but especially MRI. And MRI, it you can see it both sagittal, sorry, there is coronal oblique view. In coronal oblique view, in the superior labrum, there is high signal intensity, which is directed laterally. Which is directed laterally. It indicates superior labral injury. Also, you can see that is superior labrum. There is changes in the high signal intensity change. It indicates superior labral injury. And we can now see how we do a repair of the slap tear. In this video you can see enzyme after through the portal, the antero superior or antero inferior portal, we can assume that that is detachment of the superior labrum both anteriorly and posteriorly. So for repair, we first debridement of the uh, tissue for creating a bleeding surface for healing of the labrum with the bone gland or superior gland. After creating the insertion or double loaded anchor through the superior portal, into the superior portal, and shuttling all the suture to the anterior inferior glenoid rim, anterior inferior anterior inferior portal to the rim, and then shuttling passes posterior to the biceps tendon, that is posterior superior labrum, shuttling, and shuttling then passing the one of the thread of the four double loaded suture and creating a Duncan sliding non-locking knots to the posterior labrum through the uh, anterior superior portal. You can see here that is after knot tying, and it is uh, cutting of the tying of the suture. And the anterior, uh, one of the anterior suture, which is the same way we created an anterior labrum knot tying to the anterior labrum, and there is two stitches, one anterior and one posterior to the biceps anchor. This is biceps anchor cutting at the anterior suture. So Here you can see there is a both posterior labrum and superior labrum, that is slab is fixed and testing its activity to the glenoid. So it is intact. So we can see that is the labrum is repaired, superior labrum, by one double loaded suture anchor by giving one knot posteriorly and one knot anteriorly. So in conclusion, we can see there is see that several literature indicate that the arthroscopic slab repair, especially type 2 lesion with bioabsorbable suture anchors, provides a significant improvement in functional capacity and pain relief, irrespective of the activity of level. So thanks for question hearing.
Thank you very much, sir, for your excellent presentation. Sir, I have a few questions regarding the presentation, sir. Number one, sir, uh, can we treat SLAP uh, as conservatively?
Yes, usually when a slab type 1 variety, especially preying of the superior labrum, we can go conservative like regular muscle stressing, strengthening, shoulder range of motion exercise, and also including some type of uh, electromagnetic therapy like ultrasound, short wave. If there is improvement type 1 and mostly type 1 variety, that is improved, we improve within 3 months. If there is no improvement within 3 months, then we go there is some mechanical block or like clicking, blocking, locking procedure there, especially during overhead activities. In this situation, we go for the intervention like arthroscopy repair and type and other variety, as because they are in this situation bicep anchor are unstable, so we go for arthroscopic surgery.
Thank you very much, sir. Sir, is it SLAP is associated with another injury in shoulder or SLAP individually occurs?
Yes, when actually there is long standing slab tear there, uh, there is a there is a leaking of the synovial joint within the through the posterior slab, and it creates some bulb like wicket. That means synovial will go outside but do not enter again into the joint, and this is a creates a ganglionic like cyst. It creates a cyst. This cyst causes compression of the suprascapular nerve at the spinoglenoid nose, which supply the infraspinatus, and this compression causes pain or wasting of the infraspinatus muscle. Ultimately, shoulder uh, abduction or external rotation uh, is hampered, and patient come to us with muscle wasting and well as a rotator cuff insufficiency.
So, if the cyst is formed there, then what will be the mode of treatment to remove the cyst from there, sir?
Yes, it can we can clinically diagnose it as the muscle is uh, wasting, and we examination reveal it is and do not work properly, and also MRI image showing there is a cyst at the spinoglenoid region. So we can assume both clinically and as well as imaging there is a labral tear and the cyst formation, and which causes the compression of the suprascapular nerve at the spinoglenoid nose. And when we do it arthroscopically, release of the cyst or decompression, and later on we repair the labrum, so there is blockage of leaking of the synovial fluid, so patient may be improved.
Thank you very much, sir, for your nice presentation. and sharing your knowledge with us. Thank you very much, Dr. G.M. Jahangir sir, for your presentation. And I would like to thank Raj Tv and Malleus CMT Specialized Hospital for sponsoring our program. I'm Dr. Mohammad Tanvir Ashraf saying bye-bye to you and hope we will connect with you in the coming part of our program with another shoulder topic. Till then, bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.